in. I see we have about 45 on the call. We'll probably double that in the next 30 seconds or so. But just in the interest of time, because I want to give you the floor, it is just such a deep honor and privilege to introduce Dr. Peter Schmidt, who is there, even if you can't see him, little technical difficulties there in Bethesda, but he joins us. And, Peter, when we put this talk series together and came up with the list of names of who we wanted to have, it's a no-brainer that you were, one of the first names to be mentioned. For the uninitiated, Dr. Schmidt is chief of the section on behavioral endocrinology at the NIMH. He joined NIMH's intramural research program back in 1986 after completing his medical residency at University of Toronto. And over the last 30, some years, 40 years really, Peter, your lab has just generated some of the most original, rigorous science of sex steroid hormones and their role in the development of mood disorders, including a focus on perinatal depression, premenstrual dysphoria, and the focus of today's talk, which is perimenopausal depression. So I remember reading your work in graduate school and just thinking, what a legend then, and to see your continued success in the many years and decades since is just such a joy and such a boon for the field. We're so grateful to have you and delighted to hear what you have to tell us today. And so without further ado, Dr. Peter Schmidt.
Thank you, Emily, and I appreciate the very gracious and kind words, although probably somewhat exaggerated, but still nice. So today I wanted to talk about some of our studies on women who develop depression during the perimenopause. And what I'd like to specifically review are kind of studies related to these two goals. One is that in many of our studies, as Emily mentioned, where we focus on women with reproductive mood disorders, our studies in the perimenopause, I'll talk about our longitudinal study, which we've just completed, studies in which we've tried to do hormone manipulations, in particular estradiol withdrawal, in women with a past history of perimenopausal depression, and using the same basically hormone manipulation paradigm, we've looked at the potential effects of an estrogen receptor beta agonist on mood symptoms in those women. The second is because of what we identified in several of these conditions is this differential behavioral sensitivity or response to otherwise ostensibly normal endocrine events. We've also employed some in vitro models in which we've tried to understand the cellular basis for this differential response. So just as background for those of you who are less familiar with this, the menopause transition is a period of reproductive aging, which is associated with a rapid depletion of follicular, ovarian follicular cells or antral cells. And this starts around age 40. And although it's unclear what the contributors underlying this rapid depletion are, you see it. And it fits in with kind of the rise in fertility clinics and a number of other factors with women having their children at a later age. The average age of menopause, which is defined as at least a year, some people would say 6 months, but a year of amenorrhea and no menses, usually occurs the average age around 50 years. Now, this is a schematic of the three levels of control of the reproductive axis, the hypothalamic pituitary gonadal axis, with the hypothalamus as kind of the central regulator, the pituitary, and then the target of these hormones, the ovary. And so the GnRH, which is released from the hypothalamus in a pulsatile manner, is a decapeptide. It is released into the portal system and stimulates the anterior pituitary to produce its hormones, the two gonadotropins, luteinizing hormone or LH and follicle stimulating hormone, which circulate in the blood and stimulate the ovary to produce its hormones, the two ovarian steroids, main ovarian steroids, estradiol and progesterone, as well as several peptides, including inhibin are inhibin A and B. It also obviously has the hormones that are released impacts on the uterine lining in preparation if fertilization occurs and implantation. Now, these hormones also feed back in a negative feedback way, estradiol and progesterone, to at least the level of the pituitary. And then the inhibins are meant to inhibit the activity of the gonadotropins, in particular, FSH. So during a loss during ovarian aging and the rapid depletion of follicles, there is less estradiol made, although in a percentage of women, Tepper study from the society or from the study of women's health across the nation, that some women actually experience higher levels of estradiol during the perimenopause than they've ever been exposed to before, even including pregnancy. But overall, the process is a decline in follicles. Less follicles are recruited to produce estradiol. Fewer follicles go on to ovulate. And so the declining estradiol, as well as they think some decrease in inhibin, signals to the pituitary and results in increased FSH, which continues to stimulate the ovary and an effort of which probably contributes to some of the follicular depletion. So just as a schematic, these are 3 phases of reproductive life: normal cycling, postmenopause, and then the transition from here to here, which is the perimenopause. The upper panel is estradiol, the lower are the estradiol levels and progesterone levels. The lower panel is the gonadotropins. And you can see during normal cycling, if this is the first day of menses, estradiol increases. It has a biphasic pattern of secretion in the blood, with the second peak occurring after ovulation. The first main peak occurs just prior to ovulation. Progesterone secretion is largely limited to the luteal phase after ovulation, although there's a slight increase prior to ovulation. In the postmenopause, estradiol, because of ovarian failure, estradiol and progesterone levels are pretty low. With respect to gonadotropins, after the estradiol surge, both LH and FSH increase that may trigger ovulation. So there's a cyclic production of those hormones, whereas postmenopause, there's more of a tonic elevation of FSH and to some extent, lesser extent, LH. In the perimenopause, you get a mixture of some cyclicity with, as I mentioned, eventually declining ovarian estradiol secretion, fewer ovulatory cycles, so progesterone secretion has declined, but that some gonadotropin cyclicity is maintained, but at a general elevated level. And so in the fertility clinics, they used to look for an early follicular phase FSH as a marker or predictor of success in effort to capture kind of recruit follicles. So there has been efforts to classify in order to standardize people's research in this area. And the STRA criteria, which is the Stages of Reproductive Aging Workshop, have been developed, and there's been 2 iterations. And they define the menopause transition in an early and late stage, associated largely now with menstrual cycle patterns, whether it's variable, 7 days greater, or 2 or more skipped. The idea is that the ovary is becoming less functional in terms of producing sufficient estrogen and progesterone to induce regular cycles. As I mentioned before, there's an elevation of FSH. Now, the focus of our studies has been on the perimenopause, when kind of the action is happening, and that includes the first stages of the early and late menopausal transition, plus the first year after amenorrhea. So menopause, the postmenopause starts in that year after the perimenopause. So just as some additional background, epidemiologic studies have suggested that the menopause transition is associated with the 2 to 3-fold increased risk of both first onset and recurrent depression. And what question we tried to answer because we didn't see, just as background, when we were studying women who presented with depression during the perimenopause and controls, we didn't see any uh, abnormal increase or decrease in any of the reproductive hormones in that group when we compared them to reproductively matched and age-matched women who were not depressed. So we conducted a longitudinal study to ask if there are differences in reproductive function that may be associated with perimenopausal depression or that may be increase the risk. And so we recruited a group of premenopausal asymptomatic women. We saw them every 6 to 8 months in the clinic during the early follicular phase to standardize kind of when we would see them. That's between days 3 and 6 of their menstrual cycle until about 6 to 12 months after their final menstrual period. So covering the perimenopause. And we performed obtained a number of outcome measures. And today I'll be focusing mainly on our studies in which we took blood hormone measures at each clinic visit. And we also completed a structured diagnostic interview at each of these 6 to 8 month visits. And this is a manuscript that's being written up now by Constance Zhao, who is a fellow in my group and is now left to the FDA to pursue her lifelong, if it's possible, lifelong interest in regulatory medicine. So I will show some of that data. We've followed and concluded the study after following and completing work with 88 women. Each of these lines in the spaghetti plot represents a woman's course over the study, and the x-axis is everything's anchored towards when their final menstrual period occurred, which was determined prospectively. So we have their values dated prior to the final menstrual period and then up to a year or so after the final menstrual period. Each dot represents a clinic visit. And we followed women generally for an average of 6 years. The range was up to between 2 and 13 years. Now, look to focus on the red dots. These are women who developed depression, and so once they developed depression, we colored their course in red. And focusing on that group of women, we identified prospectively 20 women, 29 episodes of depression. And we found that episodes clustered, looking at the risk ratio, around the 24 months surrounding the last menstrual period. And these are the episodes in dark red, and then the episodes that we found prospectively in the course of the study are the lighter red that were outside of that 24-month window. And so, as I mentioned, we identified 29 episodes of major or minor depression by the structured interview in 22 women. And 20 of these episodes occurred in the 24 months surrounding the last menstrual period. So they seemed to cluster during that time. In 19 of these women, episodes occurred after an elevated plasma FSH, indicating that reproductive aging had preceded the onset of their depression. Only 4 of the women with perimenopausal depression had a past major depression that prior to entering the study that we identified using the SCID as well. So 18 of these 22 women had a first onset of depression in the perimenopause. Now, we measured hormones during each of these visits, and 2 of the hormones I want to focus on today are estradiol and FSH. And when you look at we had to log because they were not normally distributed, but if you look at plasma estradiol levels here on the y-axis, and again, we anchored this all relative to the final menstrual period in each of these women, that you see the model was best fit by a linear model, and we have analyzed this with multiple efforts in terms of changing. It's not a rectangular database because of the difference in the time that we followed people and when they had their final menstrual period. But early on, you see a divergence and overall a more rapid decline in estradiol that was shown here by the diagnosis and time interaction. So estradiol, and then the curves kind of converged, or the lines converged towards closer to the final menstrual period. Looking at FSH, the more of a quadratic pattern seemed to fit the the data analysis, and plasma FSH levels again early on were divergent. When we looked at the vertices of each of these curves, that the kind of bottoming out, the vertex of this inverted parabola, or not inverted parabola, occurred closer to the final menstrual period in the women with depression and earlier in the controls. So what these data suggest is that events prior to when we saw the clustering of depressive episodes seemed to put some of these women at risk, and that there would be more of a steeper decline in estradiol and a later decline in FSH with the rise, as you'd expect, prior to final menstrual period as women were entering their menopause. So, suggesting that there are differences in the reproductive function of both estradiol and FSH prior to the final menstrual period in women who develop depression, and may suggest kind of the early intervention approach of estrogen therapy that Gordon et al. Suggested in their estrogen treatment trial. So that led us to the next question. We know that, as I said, the perimenopause is associated with a 2 to 3-fold increased risk of depression. We found that these episodes clustered, and others have found this during the late menopause transition when estrogen levels are actually starting to decline more rapidly. And we also, several studies, small sample size studies, have suggested that estradiol therapy has an antidepressant effect, at least in most of the trials, a short term, but in Gordon, it had a preventative effect. So we asked the question of whether estrogen withdrawal precipitated depressive symptoms in women with a history of perimenopausal depression. So we recruited in this trial women who had a well-documented past episode of depression during the perimenopause. They were all placed on a standard dose of estradiol, 100 micrograms a day by skin patch, for 3 weeks. And those that remained that were asymptomatic were then randomly crossed over to one of two conditions. They either continued on the estradiol at the same dose they were given during the first 3 weeks under open label conditions, or they were crossed over to placebo, so that this double blind, this particular randomization, they underwent estradiol withdrawal. So if you're looking for symptoms to emerge, this was the window to be looking at. Now, to control for the hormone manipulation, we also recruited a group of asymptomatic women who were matched for reproductive state and age, and they participated in the same protocol. Now, this is an example of the results that we saw that were published back in 2015. This is the CSD severity scores, where higher scores are associated with more severe depression. And these are the women with perimenopausal depression. These first two panels, this group was randomized to receive continued estradiol, whereas this group experienced a crossover to placebo. And as you can see, they reported an increase in depressive symptoms. The controls who underwent the identical hormone intervention experienced no changes in mood during the 6 weeks. So this was a relative brief intervention, but we found a significant difference in these women. About 70% of them experienced a recurrence in their symptoms. So the next question that we were trying to answer, focusing on this group, is whether what would be the role of ER beta or ER alpha in determining this change in affective state related to estrogen withdrawal. So why ER beta? First, there's been numerous preclinical studies that have suggested that ER beta is a mediator of estrogen's effects on both affective-like behaviors as well as stress responsivity in the HPA axis. We were able to obtain a compound made by Lilly, the structures shown here, seem relative to estradiol, and this it was approved for use in humans, which is a critical thing. Actually, this is the first study in women, it was originally done as a treatment for benign prostatic hypertrophy in men. The origin of that seeming paradox is that estrogen receptor beta was first identified at the Karolinska by in the prostate of animals. So this compound had approximately a 12 to 30-fold selectivity for ER beta versus alpha, although we knew that there was a loss of that specificity once with increasing doses, and it would start overlapping with ER alpha. Importantly, which some of the other ER beta compounds that were available or were around, there was evidence that this compound did cross the blood-brain barrier, so it could be neuroactive. We designed a study very similar to the estrogen withdrawal paradigm I just showed you, where we recruited women who had a past perimenopausal depression and who responded to estradiol to kind of enhance the group. All women were placed on open label estradiol at skin patch of 100 micrograms a day for 3 weeks. And after 3 weeks, they were randomized under double-blind conditions to one of three conditions, either a low-dose LY, which presumably had the most specificity for the ER beta, a higher dose, which we wanted to make sure that we used a higher dose to try to enhance brain penetration, but at the risk of overlapping with ER alpha, and then the placebo. So this would be the estrogen withdrawal arm where we would expect symptoms to recur if we could replicate our previous findings in this independent sample of perimenopausal depressed women. So these are kind of in what we saw in the group, that all three groups experienced a drop in estradiol levels that was comparable across the three groups. So nobody was getting estradiol, even though, that was because we stopped giving anybody estradiol, and they were postmenopausal. There was no evidence peripherally of cross-reactivity with ER alpha, and we looked at LH and prolactin, which are both thought to be secretion regulated by ER alpha, and we also performed transvaginal ultrasounds to look at endometrial thickness. And in all three groups, there was no evidence of ER alpha stimulating endometrium. Just as an example of the results, this is the CSD score, again, where higher scores reflect more severe depression. Each of these bars are weeks during the trial. I've just highlighted their baseline prior to study, as well as their scores after 3 weeks of estrogen. And then these bars represent their scores, their mood ratings during the estrogen or during the double-blind conditions. And focusing on the group in red here, these are the women who received placebo. And, kind of similar to our findings of the estrogen withdrawal, we showed a significant increase in depressive symptoms over this 3 weeks in these women on placebo. So there we were replicated our estrogen withdrawal. In the women who received high dose LI, so this is the group that may get some overlap with ER alpha, although we didn't see any peripheral evidence, they didn't show a significant increase in their symptoms. So that looked pretty good. When we looked at the low dose, which was thought to be the one most specific for ER beta, we still didn't see a significant increase or worsening of symptoms comparable to estradiol withdrawal, but it kind of was it was in the same direction. And when we looked at the scores in week 6 between the three groups, there was no significant difference in the scores on low dose versus high dose versus placebo. Now, we're still looking at this data, although because there was a potentially, at least a trend for significantly more symptomatic during week 3, most of this study was done during the pandemic, so there was lots of noise interfering with symptom reporting, which we, have to account for in some way, but we may not be able to do it perfectly. But when we looked at the percentage change relative to their week 3 scores on estradiol, so here all women are on estradiol, and then we look at the relative percentage, there was a difference between the placebo, which showed a significant worsening, and either scores on the high dose or the low dose. And particularly the high dose showed that the percent change in the ratio from week 3 to week 6 was significantly lower than the placebo. Nonetheless, the data is what it is. In conclusion here, we have replicated the effects of estrogen withdrawal on symptoms in these women. So we confirmed this differential sensitivity to estrogen withdrawal or the induction of hypogonadism in these women. It's possible that our data suggests, particularly because at the higher dose seemed to have a stronger effect, is that both ER alpha and ER beta are needed for the therapeutic effects of estradiol on mood. It's also possible that the estradiol itself, its occupancy of ER beta is greater than the LY that we were administering or the ER beta agonist that we were administering. And so what we're doing now is we've partnered with a group at the National Institutes of Deafness and Other Communication Disorders, as well as the Katzenellenbogen group at UIUC. And we are looking, at least in preclinical studies, at more selective ER beta compounds that John Katzenellenbogen's group has developed. And my collaborator, Rona Hertzano at NIDCD, has a story in animal or in preclinical story suggesting that ER beta may mediate some of the hearing loss that occurs in women as they go through the menopause. So we're looking at some brain and mood measures, not that there are great mood measures in these mice, but certainly brain, and another group at NIMH is looking at circadian rhythms. So that remains to be funded. We did receive a recent funding from the Director's Challenge Award internally at the NIH, as well as a grant from the Office of Research in Women's Health to pursue these studies. So that remains to be seen. They do seem to have a selective and stronger anti-neuroinflammatory effect, which may be relevant for both hearing loss and depression and other conditions, obviously. So in that regard, let me just move to our last section where we've looked at kind of in vitro effects. Getting back to the estrogen withdrawal studies, what is the basis of this difference that we observed in the women with past perimenopausal depression, who, when they undergo the identical hormone withdrawal, they experience a recurrence of symptoms, whereas these women, who are the control women, do not. So what we did in collaboration with David Goldman's lab, Sarah Radzinskas, who works in my lab and is part of the collaboration with David, asked the question of whether is there a cellular mechanism underlying this differential behavior response to estrogen withdrawal. So what Sarah did is she used patient-derived cell lines from the women who were participated in the estrogen withdrawal study. And so our first question is whether these lymphoblastoid cells or immortalized lymphocytes express sex steroid receptor message and protein, because that's obviously the machinery that's required for the signal, at least in most steroid action. And in fact, they did. So they didn't have the nuclear progesterone receptor, but they had progesterone membrane receptors. So we went ahead with the experiment, and with the cell lines derived from both the patients and the controls, Sarah exposed them to 3 different hormone conditions: a vehicle, estradiol exposure, and then continued estradiol, similar to the women who did not develop symptoms, and then estradiol exposure and estrogen withdrawal, similar to the women who underwent or developed symptoms. And so they were collected, and in the first cohort, we performed whole transcriptome sequencing and looked at differential gene expression and then pathway and network analysis. In a second group, they were women who had perimenopausal depression, so it was an independent replication sample, They did not all participate in the hormone manipulation, but we used a different analysis using PCR to look at these genes that might have been differentially expressed in the first group. So it was provided replication. And two genes of biological interest emerged. The first was the gene for CXCL10. It's also called IP10. It's a chemokine and it's pro-inflammatory. It's a clinical biomarker for the development of heart failure and left ventricular dysfunction, which is of interest given the epidemiologic studies suggesting that even minor depression during the peri and postmenopause is associated with a risk of cardiac mortality by increased by 50%. So this seemed to be an important, potentially interesting gene that was expressed. And Sarah, these are the reads per million base count, and higher score represents increased expression. You can see in the three control hormone conditions, there was not much of a change, whereas in the women with past perimenopausal depression, particularly during estrogen withdrawal here in the dark fill, that there was a significant increase in the expression of the gene for CXCL10, and we were able to replicate that in the independent sample that showed an increased expression of this by PCR, but also Sarah could find an increase in the protein level of CXL10 in the media. Of interest is in our longitudinal study, we found, which is a little more difficult because plasma or serum is not the best place to be looking for some of these cytokines, but we didn't see any difference between the depressed women and the women who did not develop depression in their levels of CXCL10, which is shown here on the y-axis, and again anchored relative to the last menstrual period. But there's a companion cytokine, CXCL9, which is released, and we found that women who had developed depression had a higher level of CXCL9, and both of these CXCL10 and 9 are co-secreted, and they do bind to the same receptor, this CXCR3. So there may be something there that is emerging in both the gene expression and in the plasma. A second gene was the CYP7B1, which this is a cytochrome P450 enzyme that encodes the 7-alpha hydroxylase, which is involved in the metabolism of both two neurosteroids, pregnenolone and DHEA, to convert them to their 7-alpha hydroxylated form, which is thought to be a brief excretion product on its way to the full excretion. Now, it is an interesting phenomena because we saw differences in the expression, but also 7-alpha hydroxy DHEA has been found in some studies to be an ER beta agonist. So it also could be, if we saw differences, it could be a response to a homeostatic response in response to kind of declining estrogen levels. Needless to say, we saw, in contrast to the CXCL10, we found that in each of again, this is the same, higher scores represents more gene expression, that across all three hormone conditions, there was an increase in the expression of this kind of metabolic enzyme that we could also replicate in the independent sample, but that the expression levels also correlated with plasma DHEA levels in women with PMD that we had found in our previous studies looking at basal hormone levels. So we're still looking at this. I think we found in pregnenolone, which was one of the substrates for this enzyme, that there was a higher level of pregnenolone levels in the women with perimenopausal depression in our longitudinal study, but we're awaiting confirmation. So what do these suggest? That the CXCL10 could be a risk factor for both depression and cardiovascular disease, similar to the Gordon findings of estrogen therapy. It also suggests that the beneficial effects of estradiol therapy for women with depression and cardiovascular risk may differ from the women who don't. Now, what's important is our longitudinal study, as I didn't emphasize it, but the majority of women did not develop any depression. Two-thirds of them remained asymptomatic, non-depressed during the whole follow-up study. But it may be that in these women who develop symptoms, particularly depression, that they may be benefiting from the effects of estrogen therapy selectively as a different subgroup. The impact of the CYP7B1 implicates that, as others have suggested, that there may be a role for neurosteroids in the ontogeny of perimenopausal depression. So what we've tried to do in all of our studies is try to answer the question is whether or not there are depressions linked to these periods of reproductive endocrine change. And if so, what is the association or what is the mechanism whereby otherwise physiologic changes in estrogen or progesterone or reproductive function uh, alter the brain signals sufficient to produce depression in some women? And I think with the perimenopausal, just as a review, we have found prospectively that depressive episodes do tend to cluster in the late menopause, first year of the perimenopause, as we did in our longitudinal study, that there are some changes in reproductive aging related to the women who developed depression compared to those who remained asymptomatic, but that those changes occur well in advance of the clustering of depressive episodes and may represent a risk factor for these women. We found that estrogen withdrawal in two studies now, using the identical selection criteria and the same hormone manipulation, that estrogen withdrawal triggers symptoms in depressed women with past perimenopausal depression, but not the controls. So there is this differential response of depression to the otherwise identical hormone intervention. The role of ER beta remains to be defined, and we will continue to look at this, but our preliminary data suggests that it may be necessary for both estrogen receptor alpha and beta, because none of these showed the same effect that we saw with estrogen in preventing the estrogen withdrawal-induced negative effect. We are looking, and Sarah continues to do this, looking at differences in both immortalized lymphoblastoid cells, which we've identified in two, both a cytochrome as well as a potential enzyme relevant for developing depression. She also has found evidence of gene expression that may be related to an earlier menopause in the depression women, and it also in PER1 gene, one of the main coordinators of circadian rhythms that may be involved in sleep and potentially hot flushes. So we continue to pursue those findings in cell models involving both lymphoblastoid cells, but also in induced pluripotent cells that we have developed. So nothing more. I just want to get through the pulses, but just to thank the group that I work with, and including particularly Sarah Spector, the nurse practitioner, Xiaoming Wei, who's the staff scientist, and Sarah Rudzinskis, who I mentioned, who did a lot of the molecular work, in collaboration with several long-term collaborators, including Karen Berman, who did much of the imaging work, Lynette Neiman, who's our consulting endocrinologist, David Goldman, the molecular biologist, and my long-term friend and colleague, David Rubino. And then also a shout out to Pedro Martinez, who after the pandemic retired and is now bicycling around Spain with his Bad Bunny hat, but is still very much a part of the group. The new collaborator that I mentioned is Rona Hertzano, who's a neuroautologist, and we are looking at the kind of more neuroactive ER beta compounds with her. So, and I think that is it. So, thank you.
Yeah, what a incredible body of work and just so fun to see some of the stuff that's coming out soon. I can't wait to see it land. That longitudinal work in your 88 women, being able to stack against, their person-specific FMP and then look at the trajectories before and post is so beautiful. So much to do there. So I
Thank
encourage our lovely audience to now's your chance to get to ask Dr. Schmidt your questions. Let's kick off with Alex Kwan. Alex asks, can you comment on the similarities and differences in terms of the biological basis of perimenopausal depression and perinatal or postpartum depression? Relatedly, could treatment strategies for postpartum, like zuranolone, be helpful for perimenopausal depression? So, yeah, tell us about that crosstalk between these two major
Yeah.
endocrine transitions.
So in our studies, we've been able to look at it a couple of ways. Just clinically, we've looked at using kind of structured interviews, the prevalence of a past history of postpartum depression in women who we know have depression during the perimenopause. And we found that the prevalence of the reports was about 10%. So not substantially different from what you report in the general. We also looked at histories of menstrual cyclicity that would meet criteria, maybe not the severity criteria for PMDD, like premenstrual dysphoric disorder, but who had sufficient clinically, what we felt was clinically relevant uh, uh, menstrual cyclicity surrounding confined to the luteal phase. And we did see about 45%. This was a study published many years ago by Misty Richards, who I think is up in Albany now. So there seemed to be some overlap in menstrual cyclicity. And in the longitudinal study of the perimenopause, that's exactly what we're now looking at. We finally, uh, Peng Peng Kwong has had experience looking at data like logs and diaries. And the women that were in the study of the 88 women, barring a few moments where their compliance lapsed and there was brief hiatuses where they didn't do their daily ratings. We have daily ratings and weekly ratings of affective symptoms in all these women. So we're hoping to look at that soon. But there does seem to be kind of a more of an overlap in terms of the conditions between PMDD and perimenopausal depression. I don't know whether PMDD, Mickey Block has reported and others that there may be a risk, and I think it's part of the clinical acumen now that PMDD could be a risk for postpartum depression, but I haven't seen solid prospective data on that, which would be difficult to get because you have to start following women basically, after menarche all the way through to their life, which I understand you guys are thinking of trying to do, but it's a long haul. I must say that the longitudinal study that we just finished with the perimenopause, there was one woman who just would not, it was like the ever-ready battery or the ever-ready bunny just would not go through the menopause. And so it started in 1988 and we just finished it like a year ago. So uh, it's hard to do. And that's where I guess the intramural program allows for some of we don't have to worry about grant renewals and stuff. So it's, just death at the hands of the VSC, I guess. So I don't know how much either postpartum depression predicts perimenopausal depression. Doesn't seem so, but there seems to be some condition overlap. But I think in large source, there's not a lot of evidence that they are the same condition. So when we look at hormone manipulations, Xiaoming just replicated our findings from many years ago, where if it's the hormone exposure, the increase in estradiol or progesterone that seems to trigger a recurrence of PMDD, premenstrual dysphoric disorder, whereas Mickey Block's work suggests that it's the hormone withdrawal as with our work in perimenopausal depression, that it's the hormone withdrawal that induces symptoms. Now, we are, and Crystal Schiller are finding some, we're not, Ting Tien is working on the postpartum depression, our Lupron study, where we tried to look to see whether symptoms were specifically related to hormone withdrawal, and we're having a little difficulty replicating that. Symptoms emerge, but they may as likely emerge during prolonged exposure as to withdrawal. So, but we know that's not the case with the women with PMDD. Their symptoms are confined to a change in hormone. Biologically, I think when Sarah's looked at the overlap, including some of her work, which she now can finish with postpartum psychosis, that I think PMDD and postpartum depression seem to have a better overall overlap in gene expression, but there's not an overlap in the individual genes. It's just the overall upregulation or downregulation that she's seeing that kind of overlaps in PMDD and postpartum depression compared with perimenopausal depression. So there seemed to be a lot, to answer your question in short, there's a lot of overlap, but not strong evidence that these are the same people and the same conditions. So whether treatments will share and identify as being similar, we don't know how any of these treatments work anyways. Zuranolone may alter GABA function, but that may be acting through a specific ability to alter affective state and transition someone out of a negative affective state into a more positive state, and then allow other normal kind of homeostatic events to take place. So, I don't know if the biology predicts any specific treatment. So,
Thank you for that. And
yeah.
Caroline Schmidt asks, have you seen any correlation with stereotypical symptoms such as hot flashes, insomnia, headaches, in those with or without depression and perimenopause?
Yeah, great question. We were looking at that and we were able to track it prospectively. We also looked at it in our hormone withdrawal. And so in the hormone withdrawal, there was not many women got hot flushes, but the mood symptoms came in faster than the hot flushes. But there was no difference across groups and presence of hot flushes. In the longitudinal study, as many women developed hot flushes who remained non-depressed or euthymic as those who developed depression in the perimenopause. So I think consistent with Ellen Freeman's work, where hot flushes were not necessary antecedents, and in some cases occurred after the onset of anxiety symptoms. So we didn't find that hot flushes were a uniform accompaniment or a necessary antecedent to depression, similar to some of Hadeen Joffe's work, where she's found that the effects of estrogen are kind of discordant, or not discordant, but dissociated between its effects on sleep and depression versus hot flushes. So, but many women do develop hot flushes, not as many women develop depression. So there's still some differential response to the flushes that may be related to depression. So.
Yeah, it's interesting, just as an aside, this is work my group is doing in collaboration with Caitlin Castelletto and Maddie Woods and others, but doing proteomic screens by menopause stage. And it's so funny because we're seeing all of the CXCLs pop out, 9 and 10 are certainly in there. And it's we can see these nice stair step changes from pre to peri to post menopause, not associated with chronological age, but clearly this sort of proteomic signature that's changing with menopause. And those in particular, the CXCLs, are highly upregulated in women with elevated FSH and those that have more night sweats. And then it's predictive of cognitive decline decades later. So if we look at retrospective reports. So I don't know, it'd be interesting to compare.
Yeah, no, you should talk. I should put you in touch with Sarah and Xiaoming. Xiaoming is the first time in my career that I have been able to identify any changes in cognition
Mm.
was one of our Anna just reported it at SOBP, and we're with Barbara Sherwin's memory. We found in the paragraph memory, both the delayed and the immediate, that there was a decline. And these are in the women that didn't get depressed. These are women who we could confirm were asymptomatic. So we were able to eliminate that potential confound of depression impacting on cognitive performance. Now Xiaoming's looking at whether, because we asked them about their self-reports about brain fog, and we're seeing
Mhm.
whether in any way those predict, but it's I know, similar to Pauline's work, that there's clearly this report symptomatically,
Mm.
and not all women get it, but this was the first time that we could see a change of performance. We did not see changes in the Benton or in the Ray delay, so in visual
Mhm.
memory, nor in kind of working memory function. That, if anything, that got better, which is probably a practice effect because these
Yeah.
women do it. But the decline seems to be real in both the paragraphs. So,
Hmm.
um,
Yeah, I
I
mean,
think,
Doreen Rentz has looked at this, and and others. I'm thinking Neil
yeah,
suggesting that it's really in the domain of verbal learning and memory. Jill Goldstein
yeah.
has looked at this, and then all other ones are flat. I'm going to move on because there's so many people who want to ask you questions.
No, it's not bad. I definitely, as you said, we will meet.
Yes,
You
yes,
were
I
supposed
already
to.
have my laundry list, Peter, of
Well, there must be a very
candidates.
long laundry list because you told me you'd get in touch and we'd
I
meet a year
know.
ago, and so
I know, but we have so many
yeah.
ways to pick
Well,
your brain.
so,
Caroline Schmidt also asks, have you seen any connection with PMD and history of period flow rate, heavy versus light? Those with heavier periods often have more fluctuating hormone levels, question mark. Additionally, was long-term use of oral or injectable contraceptives taken into consideration in your study?
um, well, two things quickly. All the women in the study, none of them were on oral contraceptives. We have not looked that deep in terms of the past history of oral contraceptive use, but that's a good question. We do ask whether people develop dysphoria related to oral contraceptive use in that study. And then in terms of kind of menstrual cycle phenomena, in our menstrual cycle studies, we try to exclude women who have irregular cycles. So we ask that they be regular in 21 to 35 days. And people and women with dysmenorrhea or other irregular bleeding is, that's an exclusion criteria for our studies because we're usually trying to manipulate the cycle and we don't want to be including women that have a lot of irregularity. As to their menstrual cycles prior to in the perimenopause longitudinal study, again, that awaits our um, the Peng Peng's efforts to look at the diaries. But if that's something you're interested in, I'd be happy to talk with you about it because we do have a diary of their menstrual cycles as they're going through the transition, and we probably don't have specifics on menstrual bleeding and flow, but we have duration of flow in each woman. So, and since you might be a relative, although Schmidt's kind of a common name, but happy to pitch in any way.
And Catherine Moran asks, any comments on the relation between PMD and autism?
That, we're doing a study on puberty, but all of our kids are incredibly screened for, kind of normal level of cognitive function and absence of any past birth related defects. So I don't think that's the group um, to look at. I hear of people talking about overlaps in PMDD, but again, I guess the best study would be a longitudinal study from cradle to grave, and um, my understanding is, and I think that's where your consortium has, you know, got great promise for answering some of those questions. They're long studies to do, and it's hard to keep people interested, but it certainly wasn't my glowing personality that kept them in. I think it may be related to, Bad Bunny here and um,
I
but
beg to differ.
mm, so
There's a side chat happening about just how adored you are, Peter. Um,
not
well,
amongst people that know me. That's the
well, we only have 3 minutes remaining. Are there any other questions you'd like to ask, Dr. Schmidt? Well, with that, thank you so much for everybody listening. And with Dr. Schmidt's permission, we have these recorded. We'll share the talk on YouTube, so that everybody else can see it. I know there's been a buzz of excitement about folks wanting to share this, so we offer that. Peter, thank you again so much.
Thanks,
And
Emily, and please, stay in
I
touch.
have my email prepped to you with the whole team eager to pick your brain. So look for it momentarily.
Thank
Sounds
you
good.
so
I look forward
much.
to
Great
seeing
talk.
I have to go to the Endocrine Society this weekend, but then I'll be back for a while.
Amazing.
So
Alrighty.
you're not going there?
I'm not going to Endocrine Society this year. Where is it?
Chicago?
Oh, it's in Chicago.
Yeah,
Okay.
it's June in Chicago is nice, so we're going. But stay in touch, and happy to. I know what you want, and I'm happy to discuss it. So that was the.
You're the best.
But
All right. We'll talk soon.
as we talked about, I'll help you, but there's another gatekeeper involved, so I will. But I think we're in a better position now to get it than before. So
Amazing. Thank you
good.
so much.
Okay,
We'll
look
talk
forward to
soon. All right.
talking.
Thank
All
you.
Bye,
right.
guys.
Wonderful talk. Thank
Bye.
you.
Thanks.